So welcome everyone and Happy New Year. Today we have the first grand rounds of the new year and we are very excited to be welcoming Dr. Rachel Marcus, who will be talking to us about Chagas cardiomyopathy. So Dr. Rachel Marcus, by way of introduction, she is a board certified cardiologist at MedStar Health and Vascular Institute and the regional director of Echocardiography for MedStar North. There, she is a structural echocardiographer who helps with non-surgical valve repair and replacement procedures. Through her work as the medical director of the nonprofit Latin American Society of Chagas, or La Socha, she has become an internationally recognized expert in Chagas disease and provides consultation for doctors and patients alike. We are very fortunate to have her, and with that, we will have Dr. Marcus take it away.
Thanks so much for that introduction, James, and thank you everybody so much for joining today. I'm really thrilled to be invited to speak on this topic. I also wanted to let you know that I'm really honored to have, in addition to all of you, Karen Byrne, who is an epidemiologist who is really one of the world's experts in all things Chagas, on the talk as well, and she is a local resource for you at UCSF. She and Jeff Whitman, who runs, I believe, the clinical lab at Chan Zuckerberg Hospital, are very enmeshed in the world of Chagas disease, and they are really, I think, hoping to launch some screening programs there and may already be in the process of doing that. So I'm really thrilled that she can be on the call and get connected to you all. So why did I name my talk Zebras, Hammers, and Chagas Cardiomyopathy? It's really to try and help give you a perspective about how I approach Chagas disease. So for most of the people in the medical world in the United States, Chagas disease is a zebra. It's really pretty common for people to say that they've never seen it, even after I've talked to them about it, and to think that it's a disease that's only found in Latin America. On the flip side, I am the proverbial hammer where everything looks like a nail. So if I see a Latin American immigrant, particularly in a cardiology setting, but even in any other setting, actually, I'm always going to be wondering whether or not they might have Chagas disease. So what I'm hoping is that by the end of this talk, I can have hammered into you the fact that while Chagas disease is in fact still not a very common diagnosis, it is much more common than people think it is. And I'm hoping that I can convince you to start looking for it more aggressively in the patients that you see who are from Chagas endemic countries. So moving on, I thought I would just very briefly tell you about my activities at the Latin American Society of Chagas. So we're a nonprofit that evolved about a decade ago to try and fill the void for the Latin American immigrant community who faces the risk of Chagas disease. And you can see several photographs of here some of our activities, including our president, Jenny Sanchez, doing some testing in the upper left, and the three of us on the board in the lower left doing some education in the at-risk community. In the middle, there's me doing an echo on somebody who we identified with Chagas disease, doing more testing. In the upper right-hand corner, I'll just let Greg know that that's Eddie Atwood's son, Saul, putting EKGs on a patient that I see in my follow-up clinic. And Greg certainly will know that Saul Atwood, the son of Eddie, is definitely putting the EKG leads on in the right place. And then in the bottom right, that's me giving a talk to a local group of OBs to try to convince them to screen in their prenatal setting. So over the course of the past 10 years, I've been doing this work. Karen Byrne, who's on with the meeting, really got it started back in the late 90s by writing an article about Chagas disease in the United States and how to manage it. And over the course of the past sort of decades, our very small group of Chagas people in the US have been trying to proselytize about it, get people more and more aware. And actually, I think we've all been feeling like we've been chipping away at the lack of knowledge about this. But I can tell you that we still have a problem, and this is a real barrier for care for these immigrants. So I'm bringing it up because it really is a healthcare disparity issues. As I was driving to work on the DC Beltway, stuck in traffic on December 8th, I decided that I would listen to This Week in Cardiology with John Mandrola. I don't know if you all listen to him, but I find him to be very insightful. Until he said, we don't have Chagas cardiomyopathy in the United States, but we do have a lot of ischemic VT that requires ablation. So at that point, my head exploded. And once I put it back together, I wrote him what I hope was a very polite and educational letter. And about 1 week later, he issued this errata, which I was very thankful for because it meant that it went out to the community of cardiologists who listened to him, and it allowed me the opportunity to continue with my outreach. And what he said was, Dr. Rachel Marcus, a cardiologist in DC and medical director of LaSocha, wrote to tell me that there are nearly 300,000 individuals living with Chagas disease in the United States, and 57,000 of them are estimated to have Chagas cardiomyopathy. So starting off right now by telling you this is a disease we do, again, not incredibly common, but if you're seeing Latin American immigrants as in your cardiology practices, you certainly should be thinking about it. And Dr. Mandrola, very, very intelligent person, very abreast of the literature, did not know that we had it in the United States. Okay, so what is Chagas disease anyway? So the most important thing for me to say is it a neglected tropical disease, meaning is it a disease of poverty? And that's going to color the way that we talk about Chagas disease, because while there are some areas of Chagas disease that have been exceedingly well described, there has been, until fairly recently, not much money being poured into pharmaceutical research for Chagas disease because it is a disease of the poor. So it is a parasitic zoonosis that causes long-term damage to the heart, GI tract, and CNS. And on the left-hand side, you see the Trypanosoma cruzi trypomastogote in the bloodstream. And on the right side, you see amastogotes and cardiac smooth muscle tissue, which is part of why it's going to cause the cardiomyopathy that we're going to be talking about today. So who actually gets Chagas disease? Well, by and large, people get Chagas disease because they lived in a house that might have these kinds of walls with cracks and crevices, poorly plastered. And these rejuvid bugs, which are the vector that causes the transmission, live in the walls, and they come out at night. And often, hundreds of them will be running around, kind of like a cockroach infestation. And that's what keeps them close to the humans that they're then going to infect. As I mentioned, it's a zoonosis, so it also infects all the mammals. And people often will mention that they took care of rabbits, or they had aviaries or things like that, and the bugs like to live there as well. So where do we find this? Well, this is a map, and the areas in orange is places where these rejuvid bugs or triatomine insects live. And as you can see, there are a lot of different species of them, and they extend as far as the southern half of the United States. And you'll see that California is actually included in that map. They go by a variety of names, and I mention it because if you mention to your immigrant patient, do you know the pico bug, they might not know it. If they're not from Colombia or Venezuela, they might know it as the chinche, which is what people call it in El Salvador, or they might know it as the vinchuca, which is what people call it in Bolivia. So a lot of different names for it, but suffice it to say, anywhere on that map that you see orange is a place that someone could get Chagas disease as an endemic country. I'm going to focus mostly on talking about Latin American immigrants, just because for reasons that I don't have enough time to get into now, and perhaps if you want to know the answer, you could ask Karen, because she can give it to you a much better description of it. We don't have a huge problem of domestically acquired Chagas disease in the United States. So by and large, if you're going to see a patient with Chagas disease, they will be somebody who was born in a continental country in Latin America. Don't have to worry about the islands. That's not so much of an issue for the Latin American immigrant community in the Bay Area anyway. So moving along, here's what the triatomine does. This is a triatomine having a blood meal. You can see that it has a very thin proboscis that's piercing the skin. There's an anesthetic there. Some of the species are associated with painful bites. Most of them are not. At least most of my patients will tell me that they've never really remembered being bitten by the bug. And what happens is it takes its blood meal, and then it has this particular one, a very fast gastrocolic reflex. And so it poops while it's eating. And you can see in the lower left-hand corner some fecal matter that's infected with the parasite. So it's then on the human or the bug to get that infected fecal matter into either the bite wound or the conjunctiva, and that is then how the parasite gets access to the bloodstream. It's actually not all that efficient. So in general, it's thought that people are more likely to get Chagas disease if they've been exposed close to 1,000 to maybe even 2,000, 3,000 times. So one person getting bitten one time, not so likely to happen. Not a never event, but unlikely. So that's why also it's so much more common in people who grew up in houses where these bugs lived. Okay, so here's the life cycle. I'm actually, since we're talking as cardiologists, going to move through it pretty quickly. Let's move on to the next thing. So we'll talk about the phases of disease. So the first thing up top is the infection by Trypanosoma cruzi. That causes an acute phase of the illness. And in general, it's either asymptomatic or minimal symptoms, and not something that my patients would recognize as being their time that they got infected by Chagas disease. in part because, as we just talked about, there are these bugs living in the housing, and so these people are getting repetitively bitten, and so there's nothing necessarily so remarkable about one febrile illness that might make them think, oh, that's the time that I got Chagas disease. 10% of people could be symptomatic, and they can have actually a sort of more prominent febrile illness, but it can actually cause meningoencephalitis and myocarditis. And so there's less than a 5% risk of death from acute disease, but it can happen. So it's then thought that, we'll actually stop there. Sorry, let me just move right along. We're going to talk a little bit more about the acute phase. I've mentioned most of this here. This is the one example of a clinical manifestation of Chagas disease. This is called a chagoma. You can see the periorbital swelling here. It can last for a month. It tends to not be painful. It's thought to be pathognomonic of cheek cruzi infection in the conjunctiva, although it may also just be a reaction to the fecal parasite. But in general, some folks will remember having had this Romagnus sign. Parasitemia is ubiquitous at this stage of the disease, and if you treat it with antiparasitic agents, it's curative. There is not a robust data set about what happens to people who've been affected acutely. There's probably more data in oral infections, which tend to be more fulminant. But looking at some of the pediatric data sets about this, and people tend to be infected in childhood, there's probably between 5 and 10% of people who actually end up with an EKG abnormality around the time of their childhood infection. So some folks are going to have probably some significant cardiac manifestations right then. Okay, so moving on. There's some other acute presentations, and the ones that I have in red here are ones that you really might actually see in San Francisco. The first is congenital Chagas disease. There is a risk of maternal fetal transmission. In a non-endemic country, it's thought to be somewhere between 2 and 3% of infected moms. These babies are mostly born asymptomatic, but they can be born premature with hepatosplenomegaly, anemia, high drops. This actually looks a lot like Tort syndrome, which as cardiologists, we may not remember so much, but you could relay that to your PEDS colleagues. And reactivation disease, which is something that we actually see quite a bit of if we're working in the heart failure environment, because reactivation disease happens quite commonly. We'll talk about this more if somebody gets immunosuppression for a transplant, particularly cardiac transplant, but also from HIV disease, particularly if somebody has AIDS or CD4 count less than 200. And these manifestations are different than what I'm going to be talking about a little bit later. There is oral transmission. This tends to happen in the sort of northern part of South America, often related to drinking unpasteurized either acai juice or sugarcane. And again, it causes a more fulminant disease. I suppose you could be incredibly astute and pick this up in a returning traveler. But in general, we won't see that here. And finally, it can be transmitted by blood products, particularly platelets, and by donor organs. The good news for us is that there is almost ubiquitous screening of blood donations in the United States. Any first-time blood donor will get tested. So in general, we've minimized that risk quite a bit, although it's not zero. But some UNOS networks don't actually screen their donors. And we've had a case in the past couple of years on the eastern seaboard in which somebody received a donor organ that was T. cruzi positive, and they died from fulminant trypanosomiasis. Okay. So what happens after somebody's made it through their initial acute disease? Unless they've been treated with antiparasitic agent, it is thought that in general, they will pass into something called the indeterminate phase. As I mentioned, some folks already have established cardiac disease, so we might consider them to be going from acute directly to chronic phase. But a lot of people are going to end up in this sort of stage where they're living with the parasite in their body because it hasn't been eradicated, but they don't actually have any clinical manifestations. There has been some growing evidence that there might be some spontaneous cure, but in general, most people are going to end up in this stage. So then how do we know if somebody has Chagas disease? Well, this is then where serologic testing comes into play. And because it's a serologic test that all of the serologic tests are good, but they're not fantastic, you can't make the diagnosis based on one positive serology. So in general, what happens is you get a commercial lab test, and then you get confirmation through the CDC. Now, I have a red asterisk there because if you are working at Zuckerberg Chan San Francisco General Hospital, you have access to the spectacular testing of Jeff Whitman's lab, where he actually is running 2 tests right up front and then a third as a tiebreaker. And you are basically getting confirmed in-house. And so that's fantastic. I believe that at the VA and at UCSF main campus, you're sending out to Quest, which is a good test. But then when you get that back and it's positive, you will need to get confirmation. And in general, again, so the CDC is where we do that. And so then just the good news is that this is the end of significant manifestations of illness for about 70 to 80% of patients. So they live in perpetuity with the parasite and it doesn't seem to cause them any problems, and that's fantastic. Now, the data suggests that 2% per year will progress to develop cardiac disease. One of the things that I don't love about this data is that in general, it doesn't include a comparator population without Chagas disease. There are a fair number of studies that have that, and I have not published this because I haven't done it rigorously enough to be able to do so, but I did a back of the envelope calculation about what the background rate of EKG changes are per year, and it's probably 1% in those populations. So there's clearly an excess risk of developing EKG abnormalities. But as we all know, if you look over time in a patient who's got diabetes or hypertension, there's going to be some background rate of EKG changes in that population as well. So not all of that is attributable to Chagas disease. Okay, so what's next? Then we move into the chronic phase. So this is at a minimum defined as positive serology and an abnormal EKG. So I should have said that indeterminate phase disease, people have normal studies looking at the end organs that the parasite damages. So indeterminate phase is characterized by the positive serology, but a normal EKG. If you have an abnormal EKG, you are now in the chronic phase of the disease. So one of the things I want to point out here is that if the question is, does my patient have Chagas disease? That question is answered by serology. If the question is, does my patient have Chagas cardiomyopathy? That's generally a question that's answered both by serology and an abnormal EKG or another abnormal imaging test that's consistent with it. So often these people are presenting 15 to 30 years after the time of likely infection. And since they're getting infected in childhood in general, that means that they're showing up in your office when they're actually relatively young. So you're seeing people in their 30s and their 40s with significant cardiac disease. We know that about 20 to 30% of patients progress. It's really not clear who yet. We'd love to know the answer to that, although we do know that more men have significant cardiac impairment. There are questions about whether or not it's the degree of parasitemia, whether or not it's the number of times people have been infected over the years. One thing you might wonder is these patients basically have a chronic lymphocytic myocarditis, which I'll talk about in a minute. They're actually, manual laborers. And so are they doing exercise with a myocarditis? And is that a bad thing? There's different strains, and so maybe it has to do with strain type, and maybe it has to do with genetic factors in the immune response, and I'm sure there are some other things that Karen can chime in to add there. But the bottom line is we don't really know yet for sure what's going to determine who is going to progress and who isn't. I am not going to talk about gastrointestinal manifestations because this is cardiology grand rounds, but there's some pretty cool things. It's the megaesophagus and megacolon. That happens in about 10% of patients who are infected, and it's more common in South America. Okay, so let's talk pathophysiology. So there's really 4 main pathways to end up at a final common pathway of myocardial damage and fibrosis. It includes parasite persistence, and we know that there's parasite in the heart, even if we can't find it on biopsy. We see PCR evidence of parasitic DNA in areas of lymphocytic infiltrate. There's immune and inflammatory mediated injury and dysregulation. There are microvascular abnormalities, which include intimal proliferation and endarteritis and abnormal vasodilatation, which causes watershed ischemia. And then autonomic derangements, in part because there's some tropism of the parasite for autonomic nerve system termini. And it also can look a lot like a beta-adrenergic receptor. So there may also be antibodies against the autonomic nervous system. So all of that coalesces then into the final common pathway of myocardial damage and fibrosis. I feel obliged to put up the immunologic and inflammatory mechanisms here. So these are some of the cytokines that are involved. And it's basically a balance. People are more likely to do well if they have higher levels of IL-10 and regulatory T cells, but they will do worse if they have more of the interferon gamma and there's less parasite control. So just going to move through that. Now, as I promised James, we're going to talk a little bit about the cardiac pathology. So James, if you're looking at hearts in your data set, these might be what some of the Chagas disease related findings would look like. So we have 3 gross pathology specimens and 1 histopathology specimen. The first here is, and I'm showing you these because these are going to basically tell you everything that you need to know about how Chagas cardiomyopathy manifests in bad ways, because obviously these patients die. So this is a dilated heart. The arrow is pointing towards thrombosis at the apex. You can see actually myocardial fibrosis at the apex as well. So this is a patient who probably had heart failure. They may or may not have had arrhythmia from their scar, and they may or may not have had a stroke from their apex. But that is the trinity for Chagas disease: heart failure, stroke, and arrhythmia, all in one heart here. So this heart here looks considerably more healthy. There's probably LVH there. I didn't really measure it, but what you were seeing is an arrow pointing to the apex where there is a very focal, intense area of fibrosis. And this is a virtually pathognomonic finding for Chagas disease in somebody who is from the requisite area of the world. It causes focal apical aneurysms, and they're called punch hole lesions. And I'll show you an echo example of one of those. So this is a patient who might have had thrombosis at their apex. And the reason why I show you this particular slide is because if you look at their myocardium, it otherwise looks pretty healthy. So this patient probably had normal LV function, was doing just fine, and then had a massive stroke. And this could have happened at a young age. And I will show you a case example of that. So we have to worry about these Chagas disease patients because this is not something that happens in most other cardiomyopathies. We have to worry. This is why we want to make the diagnosis. And this is why we want to investigate their apexes very, very carefully. Okay, so the next one here is another heart. It's only part of the heart, but James, this is specifically the one that I said I was going to show to you. You can see that most of the inferolateral wall is looking okay, but the basal inferolateral wall is very thin and scarred. And this patient is thought to be due to watershed ischemia, but this is a patient who also likely had normal LV function or close to normal LV function and was feeling just fine until they VT'd and died. This is an intensely arrhythmogenic lesion, and it's the area of scar with Chagas disease that is indicated in many of the sudden deaths. But I really want to drive this point home too. We have to worry about these patients when they have EFs that are way higher than what we would usually worry about in our echo labs, in our clinics. And this is where the first time I'm going to say this, but I will say it again. It's very much like sarcoid. There are bizarre ways in which these diseases are extremely similar. So if you see scar in somebody with sarcoid, you're going to worry about them. You're going to worry about the arrhythmogenicity. If you see scar in somebody with Chagas disease, you have to worry about whether or not that patient's going to die suddenly without the benefit of the defibrillator because their EF is not low. And they can be quite young. Okay, and then this final slide here is a histopathologic specimen. And the reason that I put this in here is because in addition to having VTs, these patients can also have bradyarrhythmias, again, like sarcoid. So this is the His-Purkinje system. You see that it's intensely fibrosed. These are patients who can show up with complete heart block, syncope, sudden death actually from that as well. So another thing that we have to worry about. Okay, so what are the symptoms of chronic phase? In the cardiac, I'm speaking specifically about cardiac disease at this point. So patients can have angina, and this is actually in comparative studies between patients who have Chagas disease and other cardiomyopathies. The Chagas patients do actually have more chest pain, and it's thought to be due to the microvascular disease and the ischemic phenomenon that result as well. They can have exertional intolerance, either from chronotropic incompetence or just because they've got horrible heart failure. They can have palpitations and syncope, either from autonomic issues, bradyarrhythmias, and tachyarrhythmias. And I put that star there again because I really want to drive this point home. This is me hammering at you that these can be patients who have basically normal EFs or very, very mildly reduced LV function. So please keep that in mind. Heart failure from LV and RV dysfunction, and stroke, both because of the apical aneurysms and also because of atrial fibrillation. And this is actually something that is found in excess in Chagas disease patients, even when their hearts aren't as bad as what we usually worry about. So these are patients who are at significant risk for thromboembolic disease. Okay. So if your patient is confirmed positive for Chagas disease, what do you do now? And I'm starting at this particular thing from this particular perspective, because often you're going to be referred this patient for evaluation. But I think I'm going to encourage you to actually be the person who is doing the testing up front. But so now you've decided that your patient has Chagas disease and you confirm them, and so you know they really have Chagas disease. You may, if you're in the cardiology setting, you may already have done a lot of these tests anyway. But let's say ID has referred them to you for an evaluation. The first thing you're going to do is your EKG, because that's how you're going to diagnose chronic phase, and you're going to look for some of the hallmark findings that might suggest that the patient has significant damage to their conduction system, or whether or not they might have significant proarrhythmia. So what are the findings that are associated with Chagas disease? Well, this is a meta-analysis of, I think, about 49 studies with 34,000 patients, and about a third of them had Chagas disease. And what this meta-analysis found was that these are the following EKG findings that are most strongly associated with T. cruzi infection. And they include left anterior vesicular plaque, ventricular asystoles, extrasystoles. The first degree AV block, I always wondered about that because it sounds kind of like the Ohio State University. I don't know why we have to call it the first degree AV block, but so be it. AFib or flutter, a bifascicular block, and right bundle branch block. And then overall, EKG abnormalities were more common in patients with Chagas disease. So one of the things that I don't want people to walk away from this is saying, if my patient has an EKG abnormality that isn't on this list, that means they don't have T. cruzi infection, or they don't have Chagas cardiomyopathy. These are the ones that are most strongly associated. But as I'll show you, there are other findings that you can have that actually are still indicative of significant cardiac disease. So but just in terms of knowing what the textbooks are going to say about that. So this is a different way of cutting into that same question. This is looking at patients who are actually sick enough to be enrolled in heart failure clinics. The top table is from a heart failure clinic in Brazil. And the bottom is from the Paradigm Atmosphere database, because there were several sites in Latin America that were included. And so there actually were some Chagas disease patients in that study. And what we see are pretty similar findings, which is in the Chagas disease patients in the upper left, you'll see that that 50% of the patients with Chagas disease had bifascicular block. Only 5% of the non-ischemic patients had bifascicular block. But 10% of the Chagas patients had left bundle branch block. So having a left bundle, even though it's not on that list that we saw before, doesn't mean that you don't have Chagas cardiomyopathy. You definitely still see it. But what we also see is that 50% of the non-ischemics have left bundle. So if you're seeing a bifascicular block, worry. This is also true for sarcoid, actually. It's really quite bizarre. Sarcoid patients tend to have more bifascicular block or right bundle branch blocks than left bundle branch blocks. And so that's why I'm very, very intrigued by the connection between these two illnesses. If you look at the bottom table, you're going to see basically the same findings. Right bundle branch block is much more common in Chagas patients than in other non-ischemic or ischemic patients. And by the same token, left bundle branch block is less common, but definitely present in Chagas disease patients. Okay, moving along from there. Okay, so now we'll move into what you would do next. So in general, you're going to want to do rhythm monitoring in a patient who has Chagas cardiomyopathy. If the patient has a normal EKG and they don't have any symptoms, probably don't need to do it. It's not really recommended at this time. If they have palpitations, I might do it anyway, just to see what's there, because we know that the EKG isn't a perfect arbiter of whether or not somebody's heart is damaged by T. cruzi infection. But if somebody has an abnormal EKG, you really should do it. You want to be looking for any subclinical signs of bradyarrhythmias, tachyarrhythmias. And what we also know is that non-sustained VT is a poor prognostic sign and should really, I think, get you starting thinking about whether or not you need to do more aggressive risk stratification for primary prevention defibrillator. Now, remember, this is a neglected tropical disease. I do not have a strong evidence base to prove to you that this is what you should be doing. It is my fervent belief, and I will continue to support that throughout the rest of this talk. Okay, moving on. Exercise testing. It is part of the recommendations, and that's because the arrhythmia in Chagas disease can be provoked by exertion. It's also going to give you a sense for whether or not somebody has chronotropic incompetence. And I put Lionel Messi here, both because he's the greatest of all time, but also because he actually knows about Chagas disease and has a foundation in the north of Argentina to work with children who are affected. So go Lionel Messi. Moving on, so near and dear to my heart, echocardiography in Chagas disease. This comes from the Journal of the American Society of Echo. It's joint recommendations between the American Society of Echo and a whole bunch of South American imaging societies about non-invasive imaging in Chagas disease. So I put up this table here, though, in part also to remind me to explain to you the phases of Chagas cardiomyopathy. So we've talked about the acute phase. We talked about indeterminate form A. Now we're going to split into some more advanced forms. We have B1, which is when somebody has an abnormal EKG or echo, but normal LV function. And that in the Brazilian guidelines is defined as an EF above 50%. We have B2, where there's no LV dysfunction. There is LV dysfunction, but no heart failure. We have C, where people have LV dysfunction and heart failure, current or prior. And then D is basically going to be like class 4 heart failure. So what do we see on the echo? So generally in indeterminate form A, we're supposed to see a normal echo because we have a normal EKG. We know a normal EKG is associated with a very good prognosis. So in general, we're going to think that should be the case. However, we do know that there are small numbers of people who have focal wall motion abnormalities or apical wall motion abnormalities. And one of the things that I've seen as I've been reading EKGs for a cohort study of Chagas cardiomyopathy is you'll also find the patients where if on one day they come in and their heart rate's 50, their EKG looks okay. And if they come back the next time and their heart rate's 70, they've unmasked a right bundle branch block. So, a normal EKG doesn't always tell you that the patient does not have a finding on the echocardiogram. Wall motion abnormalities, as we talked about, this is a scarifying cardiomyopathy, and people will have wall motion abnormalities, and they're thinning and scarring. And the places that the parasite likes to scar the heart includes is the basal inferolateral segment, the basal inferior wall. It can also be in the mid portion of the ventricle. One place it doesn't tend to be is the basal septum, which, since I've been talking about sarcoid already, I should mention specifically, if you see that focal thinning of the basal septum in general, that's not a Chagas disease finding. At least I've never seen it, nor have I seen it referred to. And certainly we've seen it in quite a number of sarcoid cases. And then there's the apical aneurysm that we were talking about. So as the disease progresses, as you go from B1 towards D, you're going to see more and more of these findings. And there, some people will even say in stage D heart failure, you can see up to 50% of patients having apical aneurysms. And then, is there anything that we can see on, and you might see LV thrombus, so you want to look really carefully for that, and I'll show you an echo in a minute that will help really clarify that point. Is there anything that we could see in indeterminate form A that might tell us who is actually going to progress? Well, people have been looking at things like diastology. They've been looking at things like strain. Right now, I don't think we have robust enough data to be able to really know for sure that that's going to help us. In part also because as time has gone by, there are more and more people that we're investigating who have comorbidities, including diabetes and hypertension. And as we know, having abnormalities of both of those things are things that happen to you not uncommonly when you have those comorbid diseases. But we continue to look for that to see what we can find, if there's any way to figure out from form A in somebody who's indeterminate form A, whether or not they're going to progress. Okay, moving on from there. Too much time with echo. This is an echocardiogram, and I'll say now every echo that you see here is an echo from a patient at MedStar who we diagnosed. So this is an unfortunate case of a 27-year-old El Salvadorian immigrant who presented to cardiology because of palpitations. He had bifascicular block on his EKG, and he had the following echo. Because of his abnormal EKG, he also had a cardiac MRI, which showed an abnormality, and was sent for follow-up CT to investigate it, and he was lost to follow-up. I would say on this echo that it looks pretty good, although I would wonder, now that I'm a hammer, everything looks like a nail. Now I really am very scrupulous about making sure that there isn't even the most subtle apical foreshortening. So in retrospect, I would look at this and think, well, the apex looks like it might be coming down towards the base. There may be maybe we're really not seeing the true apex here. But I would certainly say that LV function was normal. So unfortunately, about 2 years after this echo, he showed up with a massive middle cerebral artery stroke, and he's now totally debilitated and incapacitated. He's the primary breadwinner for his family, and he can no longer work. And because of the MRI finding, he had this following echo done. And you can see with, I don't know if it was Definity, whatever it was, contrast, that you now see that he has what we call this punch hole apical lesion. And you could say, well, maybe it progressed from point A to now, but in fact, this is the finding that was seen on the cardiac MRI. So this is in all likelihood his cardiac source of embolus, and we missed it on the echo the first time because of that very subtle foreshortening. So when I talk with people about echo imaging in Chagas disease, I ask them to think about it like they would an apical hypertroph or a mid-ventricular hypertroph. I want people to feel that they need to be incredibly scrupulous at looking at the apex, and if there's any chance that you've missed it, to give contrast because you could miss this finding, as we did. Okay, so moving on then. We'll talk about MRI for a minute. I'm a huge fan, obviously in a resource-poor environment, which a lot of my patients are in. That can be kind of tricky to get these, but I think it really adds a lot to the evaluation of the disease. A lot of studies have shown associations of late gadolinium enhancement with Chagas disease. We also know that indeterminate phase patients can have scar, but we don't really know for sure what the significance of that is, but somewhere between 8 and 40% can. The magnitude of scar is associated with worse outcomes. And so the question would be, as in diseases like hypertrophic cardiomyopathy, is there a role in risk stratification for AICD placement? And this is something that I think a lot about. So there are a couple papers that actually came out in JACC from 2018. This is one of them. And they were looking at patients from a heart failure setting, and 71% of the patients had scar, which was mostly inferolateral. I put in red here, not all patients with bad EFs had scar. So that is another finding I want to make sure people understand. You don't have to have scar to have Chagas cardiomyopathy. It tends to be a scarifying cardiomyopathy, but if you're an MRI reader and you see a patient who's a Latin American immigrant and their heart looks bad, but they don't have scar, it doesn't mean that they don't have T. cruzi infection as the cause of their cardiomyopathy. I am totally obsessed with PET scan, but I have really no data to share with you about it. There are case reports in the United States that show that patients who were thought to have sarcoid actually do have abnormalities on PET scanning that show active inflammation. And this particular case, I think, came from the Olive View Medical Center, where a patient who had bad VT and had known Chagas disease actually had PET scanning done. I am very hopeful that we'll be able to somehow get some data to be able to include this in our armamentarium of testing, particularly because we know that it works so well in sarcoid to help us decide who should get defibrillators. Okay, moving on. Prognosis of Chagas disease. Well, it's worse than other dilated and ischemic cardiomyopathies. And for some time, people would say, well, maybe it's because the people are poor and they just aren't able to take GDMT. Well, this is a fairly new graph in the lower left from the Paradigm Atmosphere Heart Failure Database. And these patients received excellent GDMT, with the exception that they didn't get as much beta blockers as their cohorts. And that might be because they were taking much more amiodarone because of the incredible amount of arrhythmia that they have. Regardless, you can see that there's a 40% higher risk of death in patients with T. cruzi infection as the cause of their cardiomyopathy. And there are a couple of different ways to stratify risk. I include this most recent, a recent paper here on the right that basically shows you the heart failure class and ejection fraction and AHA stage. All of those are really very helpful. There's a New England Journal publication with the Rossi score, which has some clinical features in it. There's also the benefit echo sub-study, which I'll talk about in a minute. But these patients tend to have excess risks of sudden cardiac death, although with better GDMT, that's actually gone down a bit, and people are dying a little bit more from pump failure. But the older data would say a 50% risk of sudden cardiac death, 40% risk of heart failure, and 10% risk of embolic disease. So how do we stop this? How do we keep our patients from dying? So how do you treat your patient? So this is actually just a table that I put in here from the World Heart Federation, a roadmap for Chagas disease, which is just a nice reference, sort of walks you through the algorithm. But the first thing that people really want to know about is whether or not they should give antiparasitic therapy. So what is the data for antiparasitic treatment in Chagas disease? I am not going to do an exhaustive review of this because we're here at Cardiology Grand Rounds, but suffice it to say that the FDA approved benznidazole and nifurtimox on the basis of randomized controlled trials that showed that seronegativization occurred much more, actually occurred with children who were treated, and that was used as a test for cure, the seronegativization. There's observational data that suggests significant decrease in risk of transplacental passage in women of childbearing age. It is observational, but it is pretty remarkable. And right now we don't have any randomized trial evidence to help hone that recommendation. Then looking in adults who do not have cardiac disease, the only endpoints at this point are serologic and PCR, and no randomized trial evidence has assessed the impact on disease progression in somebody who's got indeterminate phase disease. This is really important, though, for people to know, because what I want to also tell you, and we'll repeat it again when I get to a different slide, is that all of your patients who have T. cruzi infection are surrounded by people who may also have it. So in some ways, once you've identified one person, you want to try to make sure that everybody around them also can benefit from the testing that they should have. And some of them may fit into this particular table. They may be children, if it's a woman who's infected, or they may be relatives who grew up in the same environment. And so knowing that there's a reason to test because you might find somebody who should get antiparasitic therapy is helpful. I'm going to move on, although you do have this table here about antiparasitic treatment here as a reference. And we'll just talk really briefly about benznidazole and nifurtimox. They both were approved by the FDA fairly recently. They are both very old medications. They both, if you'll pardon my French, suck. They are really unpleasant medications to take. About 65 to 85% of people will be able to finish a course of benznidazole, and unfortunately, you do have to worry about a very rare but real risk for Stevens-Johnson. Nifurtimox can actually cause psychiatric side effects that people really don't like, but this is what we've got for right now. Okay, so what about in cardiomyopathy? So this is an area where we do have randomized trial evidence. This was published in the New England Journal in 2015, in which 2,854 patients were randomized to benznidazole versus placebo. It was from a variety of Latin American countries. And interestingly, they were on the slightly older side, so the mean age was 55. They got remarkable follow-up, and the primary endpoint was sort of an aggregate cardiovascular endpoint, and the secondary endpoint was PCR negativization. So in spite of the fact, unfortunately, that benznidazole really dramatically improved PCR negativization rates, there was no impact on the combined cardiac endpoint at all. And I wanted to put up a table looking at some of the pre-specified subgroups, and there were only two sort of intriguing things. One was that if you looked at here at the country of origin, that in Brazil it seemed like people might have actually done better, and the other is that if patients took amiodarone, they might have done better using benznidazole. So we all know to be wary of the subgroup analysis. But one of the things it says to me is that we also don't know everything that there is to know about Chagas disease, because I've had one of Karen and my colleagues, James McGuire, who is also world expert in Chagas disease, will say the only thing I know is Brazilian Chagas disease, because that's where he worked, and this may be a disease that manifests differently in different parts of the world. In any event, what I would say about this is that these patients were included if they had 2 EKG abnormalities that were consistent with Chagas disease. So they had abnormal EKGs, they did have Chagas cardiomyopathy, but in general, they weren't very sick. Only 17% of these patients had ejection fractions less than 40%. The mean ejection fraction was 54%, and 38% of them had wall motion abnormalities, but 74% of them were class 1. So by and large, these were patients who fit into the B1 category of Chagas disease. And nevertheless, the Brazilian Society of Cardiology says that they would actually still consider treating people who are in B1 on a sort of case-by-case basis. But once your EF gets less than 50%, in general, that's where the Brazilians would stop treating. And in general, I feel like B1s are actually most of the patients who were in this trial. So I am a little confused by that recommendation. In general, I don't really favor treating. If somebody has abnormal EKG alone and they're young, that I would actually consider treating that person, particularly if it's a woman of childbearing age, where I would actually want to reduce the risk of maternal fetal transmission. But it's more on a case-by-case basis at that point. So, and there is some controversy about this in the literature, and also in a group of people who take care of patients with Chagas disease. Okay, so if we've decided that we're not going to use antiparasitic therapy, what else can we use? So these are some nice guidelines here. They're not guidelines, actually, they're recommendations, the top two in Jack and Circ. The bottom one is a guideline, and it actually is in English, and it's one of the most spectacular documents that I've read about Chagas disease in terms of pathophysiology, and then you can read about how the Brazilians think about it. But basically, what we're going to do is give these patients GDMT. And we have to say that with the caveat, which is that in general, these have not been robustly tested in purely Chagas disease patient populations. So you'll see from the Jack paper on the right, a table of studies that were specific to Chagas disease patients. You can also see the number of patients in these trials. They were tiny. But what we do know is that there's recommendations to use ACE inhibitors. These are the Brazilian guidelines and the Argentinian guidelines. There actually is an ongoing trial, I think, called Parachute Heart Failure, looking at valsartan sacubitril in patients with Chagas cardiomyopathy, aldosterone antagonists, beta blockers. We talked a little bit about how less beta blockers were being used in the paradigm atmosphere group, and that is because of the relative bradycardia, either from the amiodarone or from the intrinsic disease. And then amiodarone is really an interesting one. A lot of people in Latin America end up on it because their PVC burden is so high, and there are a lot of folks who are just not eligible for defibrillators. But I don't know if you'll remember the Jessica trial, which was an amiodarone versus placebo look at sudden death in patients with heart failure. Jessica actually had some South American sites, and I think there were a small but significant portion of their patients actually had Chagas disease. And that was the one of the studies that actually showed that there might be a benefit to amiodarone in terms of primary prevention of sudden death. Why? Well, it turns out it may actually have intrinsic antiparasitic activity. So there's some studies that are going on to look and see whether or not we should be more aggressively using amiodarone. I wouldn't say that necessarily. I don't love it, you know, when a young person, you all have plenty of experience with it, but there's that. Okay, so the next thing we ought to talk about is electrophysiology. These are patients who we've talked about have a lot of arrhythmia. I wanted to show you this echo of a guy who I met in the hospital, who was a 45-year-old, is a 45-year-old El Salvadorian immigrant who had an experience of sudden death when he lifted a bag of potatoes at the Popeyes where he was working. Fortunately, there was a policeman in line to pick up his order, and he used the AED and got him to the hospital. His first echo was a disaster. He had an EF of less than 20%. But this is about a week later, and you can see from this one view that his EF doesn't look so terrible. But he did have lateral scar on his MRI. And did confirm positive for Chagas disease. Unfortunately for this poor guy, he's uninsured and was not able to return to our hospital, and we've had a very hard time getting him ongoing care for his defibrillator maintenance. In any event, a guy who does not have a particularly bad ejection fraction who died suddenly from Chagas disease, so please remember that. Let's talk a little bit about defibrillators. So who needs one? Well, right now, the European Society of Cardiology gives Chagas a little bit of a hat tip in its guidelines, and it gives a 2A recommendation for people who have ejection fractions less than 40. We know that basal inferolateral scar is a common substrate, and we really need the data, which we don't really have. So how do we sort of try to get around this issue? Well, we know that non-sustained VT is a worrisome predictor of death. We know from the benefit sub-study, the benefit trial was that one in the New England Journal with the randomized trial. They had about half of their patient with follow-up echoes, and they found that if you had a wall motion index of 1, that you had a reasonably low risk of VT over 5 years, but not 0. And that as your wall motion index score goes up, that your risk for VT over 5 years goes up to, say, 7% if your wall motion index is greater than 1.5. You don't need that much scar to get to a wall motion index of 1.5. So if you have significant scar burden, you need to worry about whether or not your patient's going to VT on you. We also know from one of the MRI studies that if you have greater than 2 contiguous segments of transmural scar, that's going to bump up your risk. We know from another study that there seemed to be a threshold at 12.3 grams of scar. We can borrow from the hypertrophic cardiomyopathy literature about 15% of scar. We don't know whether or not PET's going to be helpful. But what I do is I really push hard. If I see wall motion abnormality, I'm going to want to get an MRI. I'm going to want to try to quantify the volume of scar, and then I would push for somebody to get a defibrillator. That's just me, but it's also because I see these patients die suddenly. Okay, so then there's the refractory VTs, and we're seeing this happen in the hospital. We don't, at Washington Hospital Center, where I see most of the sick Chagas patients, we don't really have a good stellate ganglionectomy program, and definitely don't have stereotactic body radiation therapy. But we're seeing these patients come in VT storm. So what are you going to do? Well, there's those two things, which have been used in Brazil pretty extensively and seem to work quite well. And to the EPs in the audience, you know more about how to manage this than I do. But in terms of VT ablation, one of the interesting things about Chagas disease is that the scar tends to be transmural, and also the circuits then tend to be epicardial. And so they're more common epicardial circuits in patients that relative to those who's had an MI-related scar idiopathic. So 37% of Chagas patients have epicardial circuitry. The efficacy is about 60 to 70%. You decide whatever your protocol is about whether or not you start epicardial or you try to do an intracardiac ablation first. But heading to an epicardial ablation is something that's done quite a bit in Brazil, which is, I believe, where the procedure was invented in order to take care of patients with Chagas cardiomyopathy. Okay. So we now need to address the other significant issue that these patients face, which is thromboembolic disease, and whether or not we should be using anticoagulation as a primary prevention. And what we know about thromboembolism and Chagas disease is that the apical aneurysm, even with mildly reduced EF, raises risk. We do not have a great evidence base to answer this question. There is one fairly large study from a single center in Brazil that looked at about 1,000 patients, I think, And they came up with Chagas disease, some of whom had strokes before, some of whom were actually already on anticoagulation. And they tried to figure out if they could come up with a grading system that would allow them to decide who might benefit from primary prevention. So they came up with the IPEC scoring system. The LV dysfunction got 2 points, age greater than 48 got 1 point, apical aneurysm got 1, and repolarization abnormalities on EKG got 1. And if you had greater than or equal to 4 points, then it was thought that the risk-benefit ratio would point towards anticoagulation for those patients. So that's why I go back to we really need to pay attention to the apex, because if you believe this study, which again, we don't have external validation, you are going to use that as part of your clinical determination of whether or not you might want to give somebody anticoagulation. So I also want to just show you this echo on the right. This was a patient who was, I believe, a 75-year-old immigrant from El Salvador who came into the hospital with heart failure. So it wasn't even with stroke. She had this echo. Unlike in the prior case, she obviously has reduced LV function. You can see that her apex, though, above that big thrombus is actually dyskinetic. So she probably also has an apical aneurysm. And on CT imaging, she'd had subacute infarct, cerebral infarct. Okay, so now we'll turn to the therapy of advanced heart failure. So these are things that I'm sure you've seen at your facility. I mean, I know you do them just regularly, but you've probably had Chagas patients who've had these procedures done. This is a patient who was diagnosed with Chagas cardiomyopathy on the day that he got his LVAD put in. You can see his heart's a disaster. He ended up getting the LVAD as destination therapy because he had a stroke shortly after the LVAD implantation, but he's a Brazilian immigrant, I think was 50 years old at the time. We also can use some newer therapies. So this was an interesting case. This was a guy who was thought to have non-ischemic cardiomyopathy, but I think I can convince you for the echo folks that this patient has a basal inferior scar. And so he looked very much like he had ischemic mitral regurgitation and went ahead to get a mitral clip, which I didn't show you the before pictures, but he had a pretty nice result there. And then we diagnosed him with Chagas disease after he got the mitral clip. So these patients can benefit from that. And it actually happens quite a bit because the basal inferolateral scar, the basal inferior scar, causes papillary muscle dysfunction. You're going to see bad MR in those patients. So sure, you can go ahead and give them a mitral clip. In this particular case, though, unfortunately, about a year and a half later, he came into the hospital in refractory VT and died. So it didn't fix his cardiomyopathy, but it certainly helped with his heart failure for a bit. Okay, and finally, you can transplant patients. So initially, the concern about transplant in Chagas disease was you're going to immunosuppress somebody who's got an active parasitic infection. So people were very worried about reactivation, and that was with good reason because people reactivate. And I'm going to talk mostly about the data from the United States because we use slightly different immunosuppressive regimens than in Latin America. But what we're seeing here from the CDC, which is intimately involved in basically any cardiac transplant when somebody is known to have Chagas disease, is that about 60%, 65% of patients are going to reactivate. I can tell you that at Washington Hospital Center, all of our patients with Chagas disease who've been transplanted have reactivated. So for us, it's higher than that. Fortunately, the way that we approach this is through a CDC-derived protocol in which we do PCR monitoring basically weekly for the first 3 months. You can see the protocol down below, but we also look with a parasite smear. And at least when I first started, at least one of our patients was diagnosed on the basis of parasitemia. And so we're generally not waiting until the patient actually has a clinical presentation in order to start treating them. So we get to it pretty early, and the patients tend to respond really well. Sometimes they reactivate more than once, but usually over the course of the first year to 2 years, you get that out of your system. Although the interesting thing about it is if it does present clinically, it can look a lot like myocarditis. So if you take a biopsy and you see grade 2 or 3R with eosinophils and lymphocytes, it really that could be either of these diseases. The thing that would be dispositive for reactivation would be if you actually found parasite in the tissue. But this has actually been quite complicated for people. It can also cause CNS disease. And then the interesting thing is paniculitis. So we actually had a patient reactivate fairly recently at Washington Hospital Center who came in with paniculitis, and they biopsied his skin lesions and found trypanosomes there. So in any event, it can be treated. It is something that you want to know about. So of course you want to make sure that you tested all of your heart failure patients from Chagas endemic regions, because this is definitely going to change your management here. Okay, so why does it matter to us? Well, first of all, because it should matter to us. We're doctors and we care for people, and this is a problematic disease just globally. So it's worldwide impact. This actually is a chart from fairly recently that has some good news in it, which is that from 1980 to 2010, the number of patients with Chagas disease has gone down fairly dramatically. Well, unfortunately, some of them have died, but because of really spectacular public health efforts in Latin America, there's actually also been a very dramatic reduction in acute cases. So that's really good news. Nevertheless, there's still 12,000 deaths a year. There's still around 6 million cases and 70 million people who are at risk. And now we'll talk a little bit more about the United States. So how do we know how many patients there are in the United States? I already told you the 300,000, around 300,000 number, and that's a number that we can say thank you very much to Karen Byrne for supplying us with. And that's an estimate based on the number of immigrants in the United States from each specific country of origin and the prevalence in that country of origin. So that's how we get to about 300,000. We get to the 57,000 patients with cardiomyopathy. These are studies that were actually done in the United States, and they show slightly varying numbers of percentages of Chagas disease. The first one that came out is on the bottom. That was done in Los Angeles County, and most of those patients were Mexican, but there were El Salvadorians that were a higher risk, and then areas in Mexico where there was considerably higher risk. So that's also something you need to be aware of. But basically, the seroprevalence rate in those around 5,000 people was 1.2%. The next one up is in East Boston, looking at a more Central American population. They're now at close to 8,000 patients, maybe even 10,000, still having a seroprevalence rate about 1%. The top one is one that we were involved with. That was in conjunction with Johns Hopkins, where we looked at 1,500 people in the DC area. That prevalence rate is considerably higher. And that is because DC has the highest seroprevalence rate of Chagas disease per capita of any Latin American immigrant population in the US, because our predominant country of origin is El Salvador, and we have little Bolivia in Northern Virginia. The reason why I put a red circle around 7.4 is that the group in Los Angeles County also looked at relatives of patients who were previously diagnosed with Chagas disease, and they found that they essentially had a 7 times higher risk of having Chagas disease than the general population, the background population. This is why I would like for you to think about this as a public health issue. So if you identify somebody as having Chagas disease, you're going to want to get those patients plugged in, the patient's family members, their children plugged in for testing, because you might be able to identify somebody with incipient cardiomyopathy. You might be able to treat them for cure, particularly with children. So please keep that in mind, and do not assume that anyone else is doing this, because in all likelihood, they are not. Okay, so moving along here then.
And Dr. Marcus,
am I running out of time?
We are probably a little bit past time. This is so high yield, so I don't maybe want to give you just like a couple minutes if possible to wrap up, and then
I'm almost done. Yeah. Okay.
Okay.
So this is a beautiful map. Again, a shout out to Karen Byrne for generating this with Amanda Irish and then some other people in our group. You can see that basically in the Bay Area, you've got it's around a 2% rate, 2% prevalence rate of Chagas disease in your immigrants. I'm going to move here. This I really need to get through. I'm so sorry. So seroprevalence data in cardiac populations. We've looked in heart failure clinics. We know as the EF threshold goes up, for inclusion, the prevalence goes down. 19% of patients with EFs less than 40 in Los Angeles County had Chagas disease as the cause of their cardiomyopathy. 13% of patients with EFs less than 45, and 7% of patients with EFs less than 50 at these other hospitals. In Los Angeles, Dr. Maymandy looked at her patients with bundle branch blocks from Chagas endemic regions and found that 5% of them had T-Cruzi infection, 18% though if they had bifascicular block, and 7.5% of patients with pacemakers from Chagas endemic regions had Chagas disease as the cause of their cardiomyopathy. We looked at hospitalized patients who were sent for echoes for indications that suggested they might have Chagas cardiomyopathy and do not have an obvious confounder. We found that 16% of those patients had Chagas disease. Chagas disease is just as a background, and then if their EF was less than 50%, 25% of them did. Again, we're in a very high prevalence region, but these numbers really speak for themselves. Okay, and then I just did want to say, this is again a study that Karen Byrne was involved in. This is what some data from UCSF, the main campus. Looking at the past 5 years, according to lab orders for T. cruzi infection, I want to give a shout out to the cardiology division for being responsible for most of the orders. But really only 136 patients have been tested over the course of the past 5 years. At starting off, I think 12 of them had positive initial tests, so that was 9%. But then there were some that, if you look down at whether or not they got confirmatory testing, 4 of them didn't get any subsequent testing at all. 4 of them got repeat commercial testing, which, as I mentioned, is not how you confirm Chagas disease. 6 of them had testing sought at the CDC, and 4 of them confirmed positive by CDC testing. So that's what's been done at UCSF thus far. I'm quite certain, or I hope, that after this talk, you'll be more incented to do more testing, even in patients who aren't as sick. These are barriers to care. I'm just going to leave it alone. There are so many, and it's just, I've run over my time. And then I'll just sum up saying this is a complicated disease. It's made even more complicated by the fact that it's a neglected tropical disease. These patients need and deserve for us to worry about them. So we need to make the diagnosis and remember that they're at high risk for bad outcomes. Thank you so much. I'm sorry I ran over. And if people don't want to stay on but have questions, please email me. I'm always happy to talk about it.
Thank you. Let's just get straight to the questions. Greg, do you want to perhaps ask yours?
Sure. Thanks, Rachel. It's a fantastic talk. I actually have a bunch of questions if I can ask briefly. So one, I'm curious if anyone has looked at screening for Chagas based only on AF, even atrial fibrillation, that is, in people from high-risk countries. 2, I'm sorry, sorry to bombard you, but again, this is, as James alluded to, this is fascinating, high-yield stuff. Curious if the high rate of thrombi, if there's a feeling that that's more than just the mechanical desynchrony and there's something pro-inflammatory.
Yep.
And then 3, curious if people have thought about using PET as a way to screen for those who may be especially amenable to therapy if there's ongoing inflammation.
Yeah. So the middle question, absolutely, I think there's a nice study, a nice paper that Luis Echevarria wrote about all the sort of procoagulant activity that occurs in Chagas disease. So in addition to having the substrate in the myocardium, you also have a prothrombotic state. So yes, 100%. In terms of screening an AFib, I have never seen that paper. It seems fantastic to me. And I have looked. So unless there's something new that I haven't seen in the past week, it would be a great study to do. And finally, no. And that's what I'm imploring people to try and do that. The real issue is it's quite expensive. And so until we actually get sort of a nucleus of data, it's going to be hard to convince the NIH to fund that particular study. And thus far, we've been really struggling to get it off the ground. I know the Olive View Medical Center was trying to do it, but they also got shut down because of costs. There's very little data. I mean, it's a great idea because nobody really has published anything yet. There's one study out of Brazil with 24 patients. There are a couple of case reports here. The person who publishes this in any robust way is absolutely going to get a great paper. So thanks, those were all great questions.
Okay, I was wanting to piggyback off your experience as a hammer, which I think is probably fairly unique in this topic. What do you do when you detect it? And I assume you pick up on some of these early stage people. Do you just screen more routinely? Because most of the therapies are reactive, it seems.
I mean, so part of my job at La Socha is to be out in the community doing community-based screening. So I firmly believe, and as Karen put in there, that every Latin American immigrant from a Chagas endemic country should be tested. Doesn't matter if they've got a normal EKG or not. We should be testing everyone because the risk is high enough, and the downstream implications are high. So otherwise, I guess I'm sorry, I'm not sure I followed your question.
Oh, when you pick up on those people that are largely asymptomatic or early stage Chagas cardiomyopathy, what is your practice? Is it just mostly screening? What intervals?
Okay, great question. Yeah. So basically, in that case, the younger they are, the more likely that I am to treat them. And I have benefited greatly from the fact that one of my Trop Med colleagues here in MedStar has an NIH treatment program. So people who are treatment eligible, I send to her and she treats them. Aside from that, I do try to get people in for yearly cardiac testing just to make sure that they're staying stable. And so that's what my follow-up clinic now is, got about 125 patients who I try as much as I can to see, with the pandemic kind of really threw the monkey wrench into that, but try to see them as close as I can to yearly, if not by every other year, to make sure that they aren't developing cardiac disease. And then begging them to let me test people around them. So all children of an infected mom, anybody who grew up in the same place, anybody who I can test to try to broaden the impact.
Thanks. I'm sure your cohort would be a fantastic place to start studying. Nora, I see your hand is raised. Do you want to ask your question?
Yeah, thank you, Rachel. This was superb. About I wanted to know if there was an atrial myopathy in this, because why you would expect it otherwise. Why so much conduction system stuff? That's one. Two is, if we get somebody, which we do for treadmill, isolated treadmill, or anything else really, is there a rate dependency to some of this bundle branch block that we're seeing?
Great questions. So I think the answer to your first question, I believe quite strongly, is yes. And part of that is now I've read, I think probably several thousand EKGs on patients who have Chagas disease through a Bolivian cohort. One thing we almost never see is left atrial abnormality. It's really quite wild. And these patients have big LAs. And I think it's because somehow there's an atriopathy that's going along with that. It's never really going to look like a restrictive cardiomyopathy where you see the giant atria, but I think that it is impacting the atrial tissue for sure. And that is probably why there's the excess rates of AFib.
Yeah, great.
And then I have also seen, my answer to that question is in this same data set, there have been patients who've had an abnormal EKG at 0.1 and a normal EKG at 0.2. And I wanted to investigate that further. And I do fairly strongly believe that there's rate dependency to the FTP, to the conduction disease on the basis of that sort of look back.
Great.
Zion, you had a question. I'm not sure if you're still online, but he asked, what do guidelines data say about subcutaneous ICDs versus transvenous in this population? Subcutaneous might be selected given the young demographic, but worry about the lack of ATP for VT or pacing for bradyarrhythmias.
Yeah, so there is no answer in the guidelines. That's neglected tropical disease therapy territory, I think. But I share that concern. That you might end up with somebody who does need pacing and the ATP issue.
Okay, Dr. Shakil, do you want to ask your question?
Yeah, sure. Thank you. Dr. Marcus, I'm not sure if you remember, but we were on a Chagas panel at the World Congress of
Cardiology. Yeah, absolutely. I recognize your name.
Reconnect. And this is kind of along the lines of Dr. Goldschlager's question. But so with the atriopathy, do you see atrial ectopy as in premature atrial contractions? Is that a feature? And then the other question I had is that it sounds like Chagas is a risk factor for atrial fibrillation. Do you ever see flutter, which is a different mechanism? And if you have any insight into the mechanisms of that, thank you.
On the second one, I'm going to, AFib flutter was a combined thing in that Rojas meta-analysis, the one that had the 34,000 patients in it. I've seen a flutter in Chagas disease for sure, but I don't remember what the breakdown is, and we think more about AFib. So I'm going to actually put pause on the answer now, look into it, and get back to you to try to better answer that question. PACs also is not something that shows up in that meta-analysis. So I think that, but I don't also know that I have necessarily a great answer for that. I don't think about it as being a Chagas specific thing, but obviously where there's AFib, there, maybe PACs, and I see it in the EKGs that I read, but, how often do we see PACs on EKGs that we read? So I'm going to see if I can investigate a little bit more and get back to you. I'm sorry, I don't have an answer right off the top of my head. But
that sounds great. Thank you. Great talk, and I'll send you an email.
Super.
And I think one last one, if Dr. Abraham is still online, I think she may have had to go. But she asked about a specific patient with a lateral aneurysm, LV dysfunction, and recurrent VT. Would you anticoagulate, just knowing those features?
Yeah, that's a great question. I mean, we usually think about it in terms of the apical aneurysm, but again, we're sort of in an evidence-free zone. So how bad is the EF? I mean, if the EF's pretty bad, then I might think about it. But if the patient, I mean, we could talk shared decision-making. I would say that most of my patients don't have the requisite healthcare literacy to be able to engage in that level of conversation. But I worry, I really do, because a big embolic stroke's a bad thing. So I'm afraid that's not a super satisfying answer, but I think if the EF was down, I would consider it if the patient otherwise seems like they're at reasonable risk.
All right, well, unless anyone has any more questions, thank you again for this wonderful talk. I think it's going to be practice changing in San Francisco. So.
Yeah, as I mentioned, well, now there are a few people on the line, but great opportunities for fellow studies, great opportunities. And you have, as I mentioned, with Dr. Byrne, just right there, you've got real expertise in the city. So, and Jeff Whitman to help with testing. But thank you so much, and please feel free to contact me if you have any additional questions. Thanks.